experts meet. Online learning, practical and sweet. Every Saturday, 9 a.m. Central Time. YouTube, Facebook, X, and LinkedIn. Online.
Hey, good morning, everyone, and welcome to UroNurse. I'm your host, Vic Senese. Glad to have you on board. Hey, if you're watching us, be sure to like and subscribe because it helps the program. Good reason to do it. And we're joined today by my co-host, Lori Atkinson. Lori, how are you doing today?
I'm doing well. How's everybody doing? It's a beautiful day, 70 degrees, and then tomorrow it drops.
Crazy weather that we've been having. I mean, it was just
crazy.
like so nice. I was out yesterday with my granddaughter because she just had she's 2 years old and she has all sorts of strength and energy to burn off. So I took her down by the lake and let her run around picking up sticks. So it was something to do.
That's nice.
But yeah, it has been beautiful weather, but it's scary. It's a little too soon for it. Flowers are starting to come up, and I don't know.
It's a tease.
What'll happen when we get our next big snow, right?
Exactly.
All right. Well, let me bring up my thing. So today's episode is going to be me presenting, so I'm going to be doing that. And
Vic,
today,
Vic, real quick. Sorry, in your background, you're sounding really far away.
Let's see if I move my mic a little closer. Is that better?
No, it's almost like I don't know. It's
getting some kind of issues on the mic. Huh?
We can hear you, but it's
but it doesn't sound close.
It doesn't sound
let me
great.
Real quick because I don't want to have the audio. Good reason. Should be a lot better now, right?
Oh, much better. Much better. Back to normal.
Good old StreamYard decided to pick the wrong microphone. So I had to switch it. All right. Well, I'll go ahead and start now. Forget what I was saying when you couldn't understand me. Hey, today I'm going to be speaking on vasectomy. Vasectomy is one of the most common and trusted procedures in men's health. But what happens when the pain doesn't go away? Today I'm talking about long-term pain after vasectomy. This was a topic that was requested, so that's why I decided to do it. It's a topic every healthcare professional should understand. How common is post-vasectomy syndrome? What are the underlying causes? And when should you intervene? And how often do you counsel patients effectively? So let's get going on that right now. So today we're going to talk about long-term pain after vasectomy, otherwise known as PVPS, post-vasectomy pain syndrome. You'll hear me using the initials sometimes and not. It's defined as a chronic or recurrent scrotal pain lasting at least 3 months following vasectomy, occurring in the absence, this is key, of proven infection or other obvious pathology. Now, while historical estimates of post-vasectomy pain have ranged from 0.1% to 54%, that's quite a range, contemporary high-quality data and guidelines, including the 2026 AUA guidelines, indicate that 1 to 2% of men experience pain severe enough to interfere with the quality of life. Now, that's a difference from the first talk about 0.01 to 54%. A significant meta-analysis of 25 data sets found an overall incidence of post-vasectomy pain at 15%, with PVPS specifically occurring in approximately 5% of subjects. We're not talking about something that's huge numbers, but as I always like to tell patients, if it happens to you, I don't care if it's 1%, it's 100% when it happens to you. Given these figures, the importance of preoperative counseling regarding the risk of chronic pain is paramount in an informed consent. Are you guys doing that? Now, here's another thing. The surgical technique can influence how much discomfort occurs. In the traditional scalpel vasectomy, small incisions are made in the scrotum to access the vas deferens, which can lead to slightly more tissue disruption, swelling, and soreness during recovery. In contrast, the non-scalpel vasectomy uses a tiny puncture rather than a cut to reach the vas deferens, typically resulting in less bleeding, less postoperative pain, and a faster recovery. While most men recover with only mild temporary discomfort regardless of technique, a small percentage may develop post-vasectomy pain syndrome, persistent testicular or scrotal pain lasting months after the procedure. Patients considering vasectomy should discuss technique options, pain expectations, and recovery with their urologist to determine the best approach for them. Now, the thing about that scalpel-free vasectomy, it's a misnomer. People think it's scalpel-free means no incision. It's still a cut. Instead of using a scalpel, it's a special instrument that has a scissor end, and you cut to make a cut. Now, here's the big difference: is how big that cut is. I've worked with a group of urologists, and the old timers used to make these big incisions, give themselves plenty of room to get in there and dissect out the vas deferens. And they would take and pull out a long section of it, feeling that was more necessary. The younger guys, tiny little things. They may have made it with a scalpel, but the incision was very small. That much smaller incision, those patients breezed through vasectomies. They had far less complaints and calls and follow-ups after that than those traditional big incision vasectomies. So personally, I think it does make a huge difference as to what technique they have. Now, the etiology of PVPS is multifactorial and often debated, but several key mechanisms are supported by clinical evidence. It's always important to look at the evidence. Epididymal congestion. This is the most widely accepted theory. Following vasectomy, continual sperm production leads to increased intraluminal pressure, which can cause the epididymal ducts to distend 2 to 4 times their original size. Makes sense to me. Chronic inflammation and fibrosis. Pressure buildup can overwhelm the absorptive capacity of the epididymis, and leading to the leakage of sperm into the interstitium. This triggers a chronic inflammatory response, cytokine release, and subsequent fibrosis. Nerve entrapment. Chronic pain may result from the sensitization of nociceptors or the entrapment of spermatic cord nerve branches within scar tissue or sperm granulomas. What about those sperm granulomas? While some evidence suggests granulomas at the vasectomy site may act as a pressure vent to reduce epididymal discomfort, others indicate they can be intensely painful if nerve branches become incorporated into the inflammatory wall. Oh boy, lots of options. So, after vasectomy, sperm continues to be produced by the testicles, but they can no longer travel through the blocked vas deferens. In some men, this pressure buildup can lead to what doctors call a micro blowout. This occurs when tiny areas within the epididymis or small sperm ducts rupture, following sperm leak into surrounding tissues. The body may react to this leaked sperm as a foreign substance, leading to inflammation, tenderness, or the formation of small lumps called sperm granulomas. For some patients, this process can contribute to post-vasectomy pain syndrome, causing aching or discomfort in the testicles or epididymis. While many microblowouts cause little or no symptoms and may even relieve pressure, others can lead to persistent pain that should be evaluated by a healthcare provider to discuss possible management options. Now, some men may notice pain during physical activity, ejaculation, or sexual intercourse, while others may feel tenderness when touching the testicle or scrotum. In certain cases, swelling or a feeling of fullness in the epididymis can occur because sperm continues to be produced but cannot pass through the blocked vas deferens. So that chronic pain, that can create an invisible burden that affects far more than just the body. When pain lasts for months or years, it can interfere with daily activities, sleep, work, relationships, and emotional well-being. Because chronic pain is not always visible to others, patients may feel misunderstood or frustrated when their symptoms are minimized or overlooked. That's really true. You can't feel somebody else's pain. You can feel sorry for them, but you don't know what everybody's going through and their struggles. And if somebody's having pain, it's really probably there. A thorough diagnostic workup is essential before initiating treatment. History. Quantify the pain using a 0 to 10 scale and characterize it. Is it aching, burning? What triggers it, such as physical exertion, sexual stimulation, or ejaculation? Do a physical exam. Focus on localizing tenderness to the testicle, epididymis, or spermatic cord. Check for the presence of a tender nodule, the granuloma. Laboratory studies. Urinalysis and cultures are necessary to rule out infectious epididymal orchitis. Imaging, such as scrotal ultrasound, is the preferred modality to rule out occult pathology like tumors or varicoceles. Findings in PVPS often include an enlarged epididymis or cystic growths. Now, there are limits to what you can get with an ultrasound. It's used to evaluate post-vasectomy pain syndrome because it does allow doctors to look at testicles, epididymis, and surrounding structures. We can find such things as swelling, cysts, fluid collections, or other abnormalities. However, ultrasounds also has important limitations. PVPS pain is frequently related to nerve irritation. Don't see those nerves with an ultrasound. Pressure within the epididymis, or microscopic changes that cannot be seen. As a result, many men with significant discomfort may still have a normal ultrasound result. This doesn't mean the pain is not real. I stressed that before. It simply means that imaging cannot detect every cause of post-vasectomy pain. Doctors usually combine ultrasound findings with the patient's symptoms, their physical exam, and medical history to determine the most likely cause and the best treatment options. So what do? Treatment for post-vasectomy pain syndrome is often approached in a step-by-step stairway approach, starting with the least invasive option and processing only if symptoms continue. Now, get this, most men will improve just with conservative therapy. So, where do we start? The first line, conservative medical management. Treatment should begin with non-invasive measures for 3 to 6 months. Pharmacology. Try the NSAIDs for anti-inflammatory effects, often combined with things like sitz baths, scrotal support, whatever works. Other analgesics for suspected neuropathic pain, consider antidepressants like the SSRIs, and anticonvulsants like gabapentin or pregabalin. Physical therapy. Physical floor therapy and myofascial release may benefit patients where pelvic floor dysfunction contributes to the pain syndrome. It's a host of things that you can try. Before you get to things like second line procedures, and these are these interventional things, spermatic cord blocks. So, and I've done a few with the docs, injections of local anesthetic into the spermatic cord can serve both as a diagnostic and a therapeutic role. A positive response, temporary 50% reduction in pain, is a strong predictor for success for future surgical denervation. Now, this one I hadn't even heard of until I did the research. Testosterone. It's experimental, but some research suggests exogenous testosterone can induce azospermia, theoretically halting sperm production and relieving congestive pressure. Although this is not the standard of care, and like I said, I've never seen it done before and only learned of it during this my research here. So if that's not working, we can go on to third line surgical interventions. For refractory cases, surgical options should be discussed based on suspected proximate cause of pain. Microsurgical denervation of the spermatic cord. This offers the highest success rate, 70 to 80% relief, while preserving the testicle. It involves dividing all neural structures in the cord while sparing the arteries and lymphatics. You kind of see what's going on right there in that picture. So these are the people that respond to that nerve block. So you know it's a neural cause. Vasectomy reversal of vasovasostomy can be highly effective, 69 to 90% success rate, for pain specifically caused by epididymal congestion or back pressure, as it reestablishes flow and decompresses the system. So this is something where if you saw that on ultrasound that those epididymal sacs were really getting full. Epidydymectomy, the most effective in well-selected patients with pain isolated strictly to the epididymis. That's you palpate and they jump. So this can be used if there's evidence of obstruction on ultrasound also. Now, I've never seen this done before in my life, but tier 4, the final treatment is orchiectomy. And this should be considered only as a last resort when all other interventions have failed, and it does not always guarantee complete pain resolution. That's kind of interesting. You can take the testicle and still whatever's inflamed can stay inflamed. So last resort, again, never saw it in my career. All right. big thing to keep in mind is you should use a multidisciplinary approach to this. Chronic orchalgia has a severe impact on quality of life, with significant associations with depression and anxiety. Well, can you blame them? Up to 86% in some chronic pain cohorts. Some patients may exhibit catastrophizing negative pain-related thoughts that can worsen the perception of symptoms. So they're just so worried that it's never going to go away that they're just building on it. A multimodal approach that includes psychological screening and referral to mental health specialists is recommended when pain is accompanied by significant mental distress. Evidence indicates that minimally invasive techniques, especially the no scalpel vasectomy or those very tiny incisions, are associated with lower rates of early complications and may reduce the risk of long-term pain compared to traditional incisional techniques. Additionally, the use of mucosal cautery combined with fascial interposition is recommended, occlusive techniques for maximizing success and minimizing recanalization risk. Our guys have always been good at separating the vas into a different plane after the procedure. All right, so there we have it. Got stuck on a thing for a second there. Let me get Lori back on the show here. And there we go. So, Lori, have you ever had a patient come into your office with this?
Oh, never.
Post-vasectomy pain syndrome. So 1 to 2%.
Yeah,
I mean, it's a pretty low number, but
yeah,
again, I took it as because I had somebody write in to learn more about it. I thought, well, it'd be a good subject to breach. We've had a couple patients in our practice, not too many. The most that we've ever gone is to do a nerve block. And sometimes I think if you can break that pain, that's kind of circle of pain, give them a relief from it, that'll help too.
sure.
Because we never had to
Yeah,
do anything past that.
we have had them. I don't think we've ever gone past, easy modifications as far as like the NSAIDs and the scrotal support
Right.
and all that, and just taking time. But yeah, we never got to denervation or the scrotal injection or the injections.
Yeah. I was surprised when I read about the use of testosterone too, because they think it could just be, the pressure from buildup of sperm not getting through this blocked tube. And I guess it's not approved practice, but they are doing it. So
Right.
it's obviously those 1 and 2% are probably the ones that make the most noise in the office, right?
Yeah. Well, we may be seeing the 1 to 2% soon here after March Madness, right?
Yeah, that was. I heard a few practices that make a big deal out of it is March Madness and get your vasectomy. So
We
I'm
have
sure
had an increase, but not as much as I expected.
yeah. If anybody in the audience has something they want to share with us, feel free to put it into the comments. Have you seen this in your practice? If you have you done kind of the same thing I just talked about, or is there anything else that you're offering here? So let's see if we'll give them a little bit of time. I did like to notice that Sacramento, California, 85 today. Wow.
Wow.
I'd also read that I think Arizona is getting 110 degrees. They said we're going to be setting records all over the country.
Wow.
So who knows? Crazy weather. But anyway, if you guys have any comments, I'm also trying a little different format today. So you notice it's a little bit shorter presentation. I think that people tend to don't like to listen as long. They like the shorter version. So kept it short and sweet. I don't see any comments coming in. I'm going to be good with not having any. If I don't see any questions, we're going to just go on to finish up the show. Lori, you have anything else you want to talk about? This a good favorite vasectomy story?
Oh gosh. Well, has anybody, I guess, ever had the failed vasectomy where they call and say, "Oops, my wife is pregnant," and it's interesting. And we've had those that, yes, unfortunately, it did fail. They either recanalized, the vas deferens recanalized and went back together. In the cases that I've seen, or you might want to check what your partner's been doing.
We had that exact thing come in. A patient had a vasectomy. It had been years, and his wife got pregnant. And the guy goes, "Hey, would you mind if I brought a sample into the office?" He said, "My wife's pregnant." She says, "I just wanted to, know is that my vas reversed itself." And we say, "Yeah, sure, go ahead, bring one in." Well, I mean, his sample was as clear as can be, no sperm per any field. It was completely empty. And the guy was nice enough to call back and said, "Yeah," he says, "my wife admitted she had an affair, that, the postman was delivering more than just mail." So,
Oh gosh.
so crazy things have happened. So
Right.
I'll leave you with one final story that I have since my 40 years of helping assist with vasectomies. You see it all. I had this guy come into the office who was super nervous, and he's here for his vasectomy. His wife said he's got this anxiety disorder. He says he's not going to calm down unless I'm with him. And normally our policy was we don't have the spouse in the room for vasectomies. It's kind of another person you got to worry about passing out. And so we just never did it. But we made an exception because this guy was just going crazy. So he comes into the room with his wife, and I just go through my typical routine that I always do. I go, "Okay, now undress from the waist down." And I turn around, and the wife dropped her drawers.
Oh my God.
She was so nervous that she heard the drop, undress from the waist down. I don't know why she thought that was going to be necessary for her, but
It's
and the
funny
guy's
that
like, he's all embarrassed. He goes, "Dear, what are you doing?"
it's
"Oh, I'm
funny
so sorry."
it's funny if you talk about passing out, but I don't know about anybody else, but when we have new team members start,
Mhm.
it's for whatever reason, when they see the vasectomy for the first time, those are the ones you got to watch dropping, because for some reason, I don't know
Oh,
if they're
yeah.
just not used to it, or it's the smell, that smell of burning flesh.
The
Anybody who
burning
uses
flesh.
pottery,
Yeah.
that
Yeah.
gets to them. So I always have them go in with somebody else, and I'm always like, please, if you start feeling nauseous, sweaty, sit down, just sit down.
Yeah. And sometimes it's the one you least expect. I mean, we've had
Right.
several patients pass out during a vasectomy because a lot of these are young guys and they get nervous. But it's always the big trucker dude who, "Oh, yeah, I'm fine, no problem." And, next thing you turn around, he's turning white.
And
So,
they always have the same response when they feel like they're going to pass out. The first thing I've noticed in most patients, they'll start getting fidgety with their hands
yeah.
like this. And then they start, sweating, and you kind of know before it happens. And we always keep our patients for about 20 minutes after the vasectomy. If it's in the office under a local, we
Yeah.
keep them in there for 20 minutes just to watch them, to make sure, because sometimes it's after they get up and they, leave
They
the
suddenly
office.
think, "What did I do to myself?" And
Right.
yeah,
It's the
you're right.
anxiety
You
that
gotta watch.
builds up. Yeah.
All right. Well, if you guys have any other questions, I don't see anything coming through. But if you have suggestions, go to uronurse.com. You can always put it in there. It probably will end up being a program. So it's always good to come up with ideas. All right. Now, next week, I will not be talking. We're being joined by Dr. Barber.
Can acupuncture actually reduce sexual pain, pelvic dysfunction, and chronic pelvic pain syndromes? In this powerful episode of UroNurse, host Vic Senese sits down with Dr. Jordan Barber, a New York City-based integrative medicine specialist with more than 20 years of clinical in helping patient address issues they're often too uncomfortable to discuss openly. Dr. Barber focuses on evidence-based, non-invasive approaches, including acupuncture for pelvic pain, dry needling therapy, pelvic floor muscle focused treatments, integrative medicine for sexual dysfunction, chronic pelvic pain management. Join us on March 28th at 9 a.m. Central Time to learn more.
Yeah, so join us next week if you want to learn more about the use of acupuncture. Not something that I think you see a lot of in practice, but I guess it's something that works. Have you ever had acupuncture, Lori?
Never.
Never. I had the dry needling that they refer to, where one of the physical therapists had studied that, and they did it for my back. It didn't help my back, but
Yeah.
I have heard a lot of people claim it does give a lot of great recovery. So we'll see what Dr. Barber has to say next week on UroNurse. And until then, enjoy this great weather, because it's not going to last, folks. So get out
Absolutely.
there, do whatever you want to do, and pretend it's summer for a day.
Yep.
All righty, Lori, thanks for coming on, and we'll see
All right.
everybody next week on UroNurse.com.
So here's to the mornings, the coffee, the
and a head full of dreams.